So welcome back viewers. So in today's session we are going to discuss about the motor pathway. So as you all know, somatic motor pathway, it is made up of two different types of tracts. One is the pyramidal tract and other one is the extrapyramidal tract. In the pyramidal tract, there is a direct connection to the lower motor neuron from the cortex. But whereas in the extrapyramidal tract, the lower motor neurons are connected with the cortex in an indirect way. So in today's session, we are going to discuss in detail about the pyramidal tract. So this pyramidal tract is the motor tract which will control all the voluntary muscular activities of our upper and lower limbs. So this pyramidal tract, it is made up of two different types of neurons. So that is upper motor neuron and lower motor neuron. So what do we actually mean by this upper motor neuron and lower motor neuron? So the fibers which arise from the motor cortex, which will end in the nuclei of the cranial nerves, the corticonuclear fibers, and the fibers which will reach up to the anterior horn cells of the spinal cord, that is the Cortico-spinal fibers. So these will make up the upper motor neuron. So the fibers from the cortex which reach up to the cranial nerve nuclei, that are the corticonuclear fibers, and which will reach up to the anterior horn cells of the spinal cord, that is the cortico-spinal fibers. So these will make up the upper motor neuron. So from the anterior horn cells, you have got one more fibers which will travel and relay in the corresponding skeletal muscle. So those will comprise the lower motor neuron. The fibers which arise from the anterior horn cells and pass through the corresponding cranial nerves or spinal nerves in order to reach the skeletal muscle. So these are what we are referring to as the lower motor neurons. So these two are connected by means of interneurons. Generally, upper motor neuron and lower motor neuron, they are connected by interneurons or internuncial neurons. So this is in general about the pyramidal tract, and it is made up of two different types of neurons. Now let us have a look at the complete anatomy of this pyramidal tract. So as you all know, how did this pyramidal tract actually get its name? So this pyramidal tract, because it is taking the origin from the giant pyramidal cells of beds, it is called as pyramidal tract. Not only that, if you remember, the pyramidal tract, when it is reaching the medulla, all the fibers, they will converge to form a elevation in the medulla which is called as pyramid. So that is also one of the reason why it has got its name as the pyramidal tract. So now, from where does this pyramidal tract begin? So it begins from the motor cortex. So at the level of cerebrum. So it will begin from the motor cortex. So where is this motor cortex located? It is located in the frontal lobe. So what are the Brodmann's areas in relation to motor cortex? Areas number 4, 6 and 8. So the fibers for this pyramidal tract, they take their origin from the motor cortex, area number 4, 6 and 8. 4 is the primary motor area and 6 and 8 will comprise the associated motor area. So after taking origin, all these fibers will converge to form the corona radiata. So they will converge in the corona radiata and then they will pass into the internal capsule. So as you all know, internal capsule has got anterior limb, genu, posterior limb, sublentiform part and a retrolentiform part. Now from where does these fibers of the pyramidal tract pass? So these fibers in the internal capsule, they pass through the genu and the anterior 2/3 of the posterior limb. So they pass through the genome and the anterior 2/3 of the posterior limb of the internal capsule. So this is the area of the internal capsule. So once they pass through the internal capsule, they enter the crus cerebri of the midbrain. They enter the crus cerebri of the midbrain. So where do they pass through in this crus cerebri? So you know this crus cerebri is divisible into medialmost 1/6 part, middle 2/3 part and lateral 1/6 part. So these fibers, they pass through the middle 2/3 of the crus cerebri. Okay, and then after passing through the crus cerebri of the midbrain, they will enter into the pons. So they will enter into the basilar part of pons. Basilar part of pons. Here they are arranged in the form of bundles. The fibers, they are arranged in the form of bundles because of the presence of this pontine nuclei, and due to this transversely running pontocerebellar fibers, they are arranged in the form of bundles. So after pons, they will enter into the medulla. So in the upper part of the medulla, they will pass through the pyramid. They will form a elevation which is called as pyramid. Later on in the lower part of the medulla, so when they reach the lower part of the medulla, they fibers out of 100%, out of the 100 fibers, 75 to 80% of the fibers, they will cross over to the opposite side. So this crossing over in the lower part of the medulla is what we are referring to as the pyramidal decussation. So in the lower part of the medulla, almost 75 to 80% of the fibers, they are crossing to the opposite side at the level of pyramidal decussation, and then they travel in the lateral wide column of the spinal cord as the lateral cortico-spinal tract, and then they finally terminate at the level of anterior horn cells in the anterior gray matter. So from this anterior horn cells, again the fibers, we will pass through the corresponding spinal and cranial nerve nuclei in order to reach the respective skeletal muscle. So that is how the skeletal muscle is getting its signal from the motor cortex, and this is what is comprising the cortico-spinal tract or the pyramidal tract. So this is about the crossed fibers which are forming the lateral cortico-spinal tract. So what is happening at the medulla? So 75 to 80% of the fibers, they are crossing over to form the lateral cortico-spinal tract. Okay, and what about the remaining 20% of the fibers? The remaining 20% of the fibers, they remain uncrossed, and then they travel along the anterior right column of the spinal cord, and then at the level of termination, they will cross to the opposite side and they will terminate in the anterior horn cells of the opposite side in the spinal cord. So ultimately, if their crossing is not occurring at the level of medulla, crossing of this anterior cortico-spinal tract is occurring at the level of the spinal cord. So what do you understand by this? So the opposite half of the body is under the control of the opposite half of the cerebellum. So so what do you understand by this? So the right cerebrum is actually controlling the left half of the body, and the left cerebrum is controlling the right half of the body. So 20% uncrossed fibers, they are forming the anterior cortico-spinal tract, and which travels to the anterior white column, and it is finally terminating into the anterior horn cells of spinal cord. So anterior horn cells, they are located in the anterior horn of the gray matter. So these fibers, they travel after terminating the anterior horn cells, they travel through the fibers which start from this. These are from anterior horn cells. The fibers which arise from the anterior horn cells are what we are referring to as the element, that is the lower motor neuron, in order to reach the specific skeletal muscle. So these will terminate at different levels at the level where they have to supply the muscle, irrespective where they have to supply the respective muscle. So I repeat, so these the pyramidal tract, it begins in the motor cortex of cerebrum from area number 4, 6 and 8 of the frontal lobe. Then it passes through the corona radiata and it enters the internal capsule, and it travels through the genu and anterior 2/3 of the posterior limb of the internal capsule, and then it is reaching the crus cerebri, where it passes through the middle 2/3 of the crus cerebri, and then it is passing through the basilar part of pons and reaching the medulla, where it is forming an elevation which is called as pyramid. And in the lower half of the medulla, 75% of the fibers are crossing over to the opposite side, forming the lateral cortico-spinal tract, which will pass through the lateral white column and terminating in the anterior horn cells of the spinal cord. And the remaining 20% which are uncrossed, they are traveling in the anterior white column of the spinal cord, and at the level of termination they are crossing and reaching the opposite side anterior horn cells in the spinal cord. So that is about the pyramidal tract. So I told you pyramidal tract, it is made up of UMN and LMN, that is upper motor neuron and lower motor neuron. In the upper motor neuron, I have mentioned cortico-spinal fibers and cortico-nuclear fibers as well. So whatever we have discussed till now is the cortico-spinal fibers. Now what about this cortico-nuclear fibers? The cortico-nuclear fibers also will take origin from this motor cortex. They will pass through the corona radiata, and at the level of the internal capsule, they will pass through the genu of the internal capsule, and then they will terminate at the level of cranial nerve nuclei in the pons at the same side and opposite side. So some fibers, they terminate in the same side cranial nerve nucleus, and some fibers, they finally terminate at the opposite side, that is contralateral cranial nerve nuclei. So those will comprise the cortico-nuclear fibers. From those cranial nerve nuclei, they will supply the individual striated muscles. So these cranial nerve nuclei which are present in this cortico-nuclear tract, they are almost similar to the anterior horn cells of the spinal cord. So from there, they will supply the respective skeletal muscle. So that is about the cortico-nuclear fibers. Now let us have a look at the specialties of this pyramidal tract. So this pyramidal tract, it is made up of almost 1 million fibers in case of humans. And the other specialty of this pyramidal tract is, so this is not completely myelinated at birth. So it will complete its myelination by 2 years. Myelination of this pyramidal tract is completed by 2 years of age. And next, the lateral cortico-spinal tract fibers and the anterior cortico-spinal tract fibers. So both are present. The lateral cortico-spinal tract fibers, they will extend up to the lower segments of the spinal cord. Lateral cortico-spinal tract, they will extend up to the lower segments of spinal cord, whereas the anterior cortico-spinal tract will only extend up to the mid-thoracic level. And next feature of interest is the representation of the human body. So the representation is different at different levels. So at the cortex, at the cortical area, the body is represented upside down at the level of cortex. So now when you reach the internal capsule, the face is represented anteriorly and the lower limbs are represented posteriorly. Now when you reach the crus cerebri, the face is represented medially and the lower limb is represented laterally. So there is a difference in the representation of the body at different levels. So at the level of cortex, at the level of internal capsule it is different. At the level of crus cerebri is different. Now coming to the fibers. So the fibers which run from the cortex to the lower limbs, they have to run a long level. So the fibers, the lengthy fibers of the cortico-spinal tract, they are present more superficially. They are placed superficially, and the fibers which will terminate at a early level, before the shorter fibers, they are arranged medially. So these are the they are arranged in a medial place. So this is about all the specialties of the pyramidal tract. So the pyramidal tract, apart from the fibers from the motor cortex, it will receive a few fibers from the sensory cortex as well. So that is from areas number 3, 1, 2. So that has nothing to do with the motor activity, but it will modulate the sensory inputs. Now let us discuss about the blood supply of this pyramidal tract. So as you all know, it is traveling through different areas. So in different areas, that particular area which through which the pyramidal tract is passing through is being supplied by a specific artery. So we will discuss it like this. So in the motor cortex, so in the cerebral cortex, the area which represents the lower limb is supplied by the branches of the posterior cerebral artery. So what is this posterior cerebral artery? This is the branch from the basilar artery, the final branch of the basilar artery. And the area which represents the face, trunk and the arms or the upper limbs is being supplied by the branches of the middle cerebral artery. Okay, and then when it is passing through the internal capsule, so that in that part it is being supplied by the branches of the middle cerebral artery. And then when it is passing through the midbrain, crus cerebri of the midbrain, it is being supplied by the branches of the posterior cerebral artery. And then lower down in the pons, it is being supplied by the pontine branches of basilar artery. And in the medulla, it is being supplied by the medullary branches of vertebral artery. And at the level of spinal cord, it is being supplied by the segmental branches of the anterior spinal artery. Anterior spinal artery. So it is being supplied by different arteries at different levels. So any vascular insufficiency can cause a condition which is called as hemiplegia. So what is hemiplegia? It is paralysis of one half of the body. So paralysis of the right upper and lower limb, or paralysis of the left upper and lower limb. So that clinical condition is called as hemiplegia. So any lesion which affects this pyramidal tract at any level above the spinal cord will cause hemiplegia. It will cause a UMN, that is upper motor neuron type of lesion. It will cause a hemiplegia. So how do we know the level of lesion? So the level of lesion is known by the other associated signs and symptoms. So we will have a look at each individual level. So suppose we take the motor cortex. We are taking the dominant cortex. If the dominant cerebral hemisphere is being involved, along with the so we all know, if the right side cortex is involved, left side hemiplegia will be there. So that is opposite side hemiplegia. So we are going to refer that as contralateral hemiplegia. So contralateral hemiplegia is common at all levels. But basing on the other cranial nerve involvement, we will determine the site of lesion. So if the lesion is at the level of motor cortex, there will be a contralateral hemiplegia, and along with that you will have aphasia, that is difficulty in speech, if the dominant cortex is involved. So now if we have a lesion at the level of internal capsule, so there will be a contralateral hemiplegia, and along with that you will have a ipsilateral, that is same side UMN type of, that is upper motor neuron type of 7th cranial nerve palsy, that is facial nerve palsy. So along with contralateral hemiplegia, patient will also have deviation of the angle of the mouth because the facial muscles are being involved. So that is at the level of internal capsule. Now, if the lesion is at the level of midbrain, that is at the level of crus cerebri, along with contralateral hemiplegia, patient will have ipsilateral, that is same side, LMN, that is lower motor neuron type of third cranial nerve palsy. So that is oculomotor nerve palsy. So the extraocular muscles will be involved of the same side. So if the lesion is at the level of pons, so along with contralateral hemiplegia, patient will have ipsilateral element type of, that is lower motor neuron type of 6th and 7th cranial nerve palsies. So you know the 6th and 7th cranial nerves are associated with pons. So if the lesion is at the level of medulla, along with contralateral hemiplegia, you will have ipsilateral 12th cranial nerve palsy. Element type, lower motor nerve, that is the tongue muscles will be involved if the lesion is at the level of medulla. So if the lesion is at the level of spinal cord, patient will have only contralateral hemiplegia with no cranial nerve involvement. So that is how we determine the level of lesion in the pyramidal tract involvement. So basing on the other cranial nerves which are involved and the other symptoms which occur along with the contralateral hemiplegia, we will determine the site of lesion of the pyramidal tract. So what are all the signs we elicit in case of hemiplegia? So what are all the features we see in a patient with pyramidal tract palsy? So obviously one thing which we all know is patient will have hemiplegia on the opposite side. That is paralysis of the one half of the body on the opposite side. So right side cortex is involved, left side hemiplegia will be there. So then you know the upper motor neurons will generally have a control over the lower motor neurons. So the hemiplegia which we are referring to is the upper motor neuron type of palsy. So because the upper motor neuron is now not having any control over this lower motor neuron, there will be an increased muscle tone. So that will lead to spasticity, and this is the hypertonia. Okay, so we refer to this as the spastic paralysis. So other feature or the other sign which we elicit is Babinski's sign. So what is this Babinski's sign? So when you gently stroke over the lateral border of the sole, there will be a dorsiflexion of the great toe with the fanning of the remaining toes like this. So that is considered as Babinski's positive. So that will be positive only in patients who have got hemiplegia. In normal people, if you stroke along the lateral aspect of the sole, there will be a plantar flexion of the toe, or otherwise it will remain in the same level, but there won't be any dorsiflexion of the great toe. So if there is a dorsiflexion, it indicates UMN palsy of the pyramidal tract. Okay, so this sign is positive in UMN type of palsy of the pyramidal tract. Even without having any palsy, this sign will be positive in children below 2 years of age. So why is it so? That is because, you know, the pyramidal tract, it is not myelinated. It is not completing its myelination until 2 years of age. So that is why they can show some sign, positive Babinski sign up to 2 years of age. Next, the patient will have absent abdominal reflexes. So if you stroke over the abdomen, lower half of the abdomen, so if you stroke over the lower half of the abdomen, there won't be any abdominal reflex, and absent cremasteric reflex. So the patient, we won't having the any cremasteric reflex as well. So if you stroke around the inner aspect of the thigh, the patient won't have any cremasteric reflex. So these are all the signs which we can elicit in case of a lesion of the pyramidal tract. So in general, clinically, all the conditions which we see, the pyramidal tract is generally involved at the level of internal capsule. So at the level of internal capsule, you can see many fibers which will pass through within a small area. So even a small tumor or any small vascular insufficiency over there can lead to a dense hemiplegia. All the clinical hemiplegia cases what we generally see in the ward are because of the lesion at the level of internal capsule, that is the territory of the middle cerebral artery. So the middle cerebral artery is generally involved in this. So the signs and symptoms, I repeat, the patient will have hemiplegia, and patient will have a spastic type of paralysis, and there will be a hypertonia, and there will be a positive Babinski sign. There will be absent abdominal reflexes, and there will be absent cremasteric reflexes, and basing on the site of lesion, the individual cranial nerve involvement. As we discussed earlier, if it is at the level of midbrain, the third cranial nerve will be involved. It is at the level of pons, 6th and 7th cranial nerve, and if it is at the level of medulla, the 12th cranial nerve will be involved. So the signs and symptoms of different levels will depend on the level of lesion. So thank you for watching.